Good afternoon, everyone. Thank you for your patience and thank you for joining us for this wonderful talk that will be given to us by Dr. Dlwati. I think he's joined us now. So without further ado, I would like to introduce Dr. Dlwati. He's a specialist neurologist based at Albert Luthuli, Inkosi Central Hospital, and he's also a lecturer at the University of KwaZulu Natal in the discipline of neurology. He's got an interest in HIV, neurology, and is also currently running the neuromuscular and the neuroimmunology clinic with special interest as well, again, in neuro-ophthalmology at Inkosi Albert Luthuli Central Hospital. Without wasting any time, I'd like to open the floor for Dr. Dlwati to just give us his views on autoimmune encephalitis and psychosis. Over to you, Dr. Dlwati. Thank you.
Okay. Okay, I'm sorry about the whole connection issue. I think we've got a connection problem from the department, from the neurology department. And then I will try and go through the presentation as looking at the most salient points of autoimmune encephalitis as well as psychosis. Okay, to start from the beginning, one of the things we're going to look at the basic science of autoimmune encephalitis, and then we'll focus more on the diagnosis as well as treatment plans of autoimmune encephalitis. As I said, that is an autoimmune disorder, which is immune-mediated inflammatory disorder involving the brain. It can involve the meninges as well as the spinal cord. And initially it was described as a paraneoplastic disorder. And during that time, when it was described as a paraneoplastic disorder, it's because they were identifying the onconeural antigens to anti-Hu and neoplasms. However, during this time, it was not clear whether these antibodies were pathogenic to the neural system and causing the immune disorder. And then in 1995, they identified the antibodies which were directed against the VGKC channels. And they noted that these patients responded to immunotherapy, and it was mainly identified in those patients who were presenting with neuromyotonia and limbic encephalitis. And initially, because the paraneoplastic antibodies were said as paraneoplastic limbic encephalitis because of the associated memory disturbances, which were associated because it was involving the limbic system. And then subsequently in 2005, Dalma identified the antibodies against the glutamate subunit of the NMDAR. And that's when it was found to be associated with ovarian teratomas. And subsequently in 2010, then they identified that these patients, which were initially identified as a VGKC abnormality antibodies against the VGKC, actually these antibodies were not binding directly to the VGKC, but were binding to the leucine-rich glioma inactivated protein. That's when all the new antibodies were identified and the NMDAR antibodies were identified. And however, during this time, that's when they noted that there were some specific types of encephalitis which occur, which were related to oligodendrocytes, mainly the MOG antibodies, and is one of the commonest cause of brainstem encephalitis. And then they also noted there's involvement of the astrocyte, which is causing astrocytopathy. And in these conditions, they noted that these are non-paraneoplastic autoimmune processes, not related to any underlying malignancies. And they mainly reflect dysfunction of the limbic system in these cases, and which presentation of limbic abnormalities. The prevalence is estimated at about 13.7 per 100,000. And recently, there's an increased number of cases, probably related to the fact that there's improvement in the knowledge and the testing of the antibodies in these patients. So we're seeing an increasing number of patients which are reported with autoimmune encephalitis. And clinical presentation can be diverse and depends on the specific underlying antibodies. However, it has been divided into three groups based on the localization of the respective antigens, which can be intracellular in the cytoplasmic or nuclear, or can be in the synaptic site, the cell surface, and involving the membrane bound. And these differ in response to treatment as well as the prognosis in these patients. That's why were subdivided, these antibodies. And the antibodies which target the neuronal cytoplasm are mainly the paraneoplastic antibodies, which the common one which we usually see is the anti-HU, which is related to small cell lung carcinoma. And these are the patients who present with limbic encephalitis, and they have associated ataxia. And then in males, one of the most commonest one is the anti-NMDAR, which is associated with the tumor of the testis. So when patients who present with features suggestive of limbic encephalitis with memory disturbances, you have to look for any evidence of paraneoplastic disorder, especially testicular tumors. And then however, these antibodies, as I said, they are not pathogenic. They are mainly in the intracellular region. And then the antibodies which are mainly in the synaptic sites, those ones in the synaptic sites, they commonly get degraded before they attach to the target antigen and may not be pathogenic. However, we do see those patients, especially with the anti-GAD65 antibodies, and which is usually associated with thymoma. They commonly present with cerebellar disorders. However, these patients can present with the form of limbic encephalitis and presenting as autoimmune encephalitis. The most common ones which we usually see is the ones which are associated with the cell surface synaptic antigens, which were previously designated as VGKC autoantibodies. And the most common one which we commonly see is the NMDAR encephalitis, which is usually associated with ovarian teratomas. However, we do see the LGI1 and the CASPA2 autoantibodies associated with this. And these antibodies, they are targeting the neuronal cell surface, and they bind to the extracellular antigens and are more likely to be pathogenic. And as I said previously, they were related to VGKC. However, subsequently, it has been noted that they just involving the multiple new proteins associated with the VGKC. The paraneoplastic, they do not cause neurotoxicity directly. However, they've been found to be valuable biomarkers of underlying malignancies. And they are also markers of T-cell mediated immunity against the neoplasm. And the neuronal damage is mainly mediated by the cytotoxic T cells and with autoreactivity against the neuronal structures in these patients. And then the ones which involve the surfaces are mainly antibody-mediated paraneoplastic autoantibodies. And the common one which we see is the NMDAR, and is mainly identified based on the CSF IgG1 antibodies, which are targeting the glutamate receptor in the brain and in the meninges. And it's followed, the commonest one is the LGI1 as well as the CASPA2. And the pathogenesis of encephalitis is mainly mediated by the IgG1 subclass. And there's the complement and neuronal injury in these patients, especially those patients with NMDA encephalitis, is not evident in the brain tissue in these patients, and which implies the recovery, which has implication on the recovery of these patients. However, you do see the other autoimmune antibody-mediated encephalitis, which includes the LGI1, caspar-2, AMPA, and the GABA-A, GABA-B. There's quite a number of other antibodies which have been identified since the initial identification of these antibodies. However, the LGI1 and the caspar-2 autoantibodies are predominantly the IgG4 subclass. And usually the LGI1 and the caspar are associated with complement activation and neuronal loss. So in these patients who present with LGI1 and caspar-2, they usually show less severe clinical manifestations with faster recovery than the NMDA encephalitis. However, the only problem with LGI1 and caspar-2 is that they've got long-term cognitive impairment and hippocampal atrophy, which is related to the complement activation and the neuronal injury, which is seen in these patients, as compared with the patients with the IgG1 autoantibody, which is mediated in NMDA encephalitis, and which usually did not show any significant atrophy unless the patients are not treated early during their presentation. The immune reaction in these patients can be acute or subacute, and it has been noted that most of these patients, they present with psychiatric symptoms in the first week of their presentation. And that's one of the things which has been noted, that these patients, the initial presentation are the psychiatric symptoms, and seizures occur, but most commonly they can occur on the second week of the presentation. And memory abnormalities, they can occur in the first week, and cognitive dysfunction occur in the first week of the presentation of these patients with the autoimmune encephalitis. You do get the chronic presentation, which is common with the caspar-2 and the LGI1. However, when a patient who's presenting with chronic presentation, you need to look for features suggestive of neurodegenerative disorders or other etiologies as a cause for the autoimmune encephalitis. Commonly, the clinical cause is a monophasic illness. However, you do see relapses, although they are rare. Most commonly, the relapses occur because of insufficient treatment or rapid interruption of treatment in these patients with immunotherapy. And in those patients with a paraneoplastic disorders, they tend to have a progressive course, and they tend to develop, especially will develop with paraneoplastic cerebellar disorders. However, if you treat the underlying malignancy, the disease tends to plateau once there's effective treatment of the underlying malignancies. The other triggers in autoimmune encephalitis mainly involve infections with a herpes simplex virus, and the HSV can mimic the autoimmune encephalitis even with neuroimaging. When you go to the neuroimaging, that's one of the things you'll be able to see what's going on in these patients. And then you can get immune modulating therapies, and as well as immune checkpoint inhibitors, which can trigger the autoimmune encephalitis. And the presentation in these patients can be variable. They can have variable symptoms, and especially with the NMDAR presentation, they tend to present with psychiatric features. However, with LGI1, they do have psychiatric features, but the one thing which is more common with the LGI1 is the facial-brachial dystonic seizures. And the caspar-2, then they tend to present with hyperexcitability in these patients, and as well as limbic encephalitis. And then you can get variable presentation depending on the presentation of the present autoimmune disorder. NMDAR most commonly occurs, it peaks at the age of about 20 years, However, the LGI1 peaks at the later stage at about 66 years. Those are the time whereby you find that these patients present with the LGI1 disorders. The NMDAR mainly was first described in 2005. However, Dalmal identified the autoantigens in 2007, and then that's when it was discovered that it's a pathogenic autoantibody. And one of the things with the NMDAR is that it primarily affects the young patients, most commonly females, with a median age of 21 years. And after the age of 45 years, the male to female ratio is balanced in these patients. And large proportion of these patients have got associated ovarian malignancies with this. And they tend to have an overlap with the demyelinating syndromes. And it has been found that some patients with NMDAR encephalitis may develop concurrent or separate episodes of a demyelinating disorder in these patients. And one of the things when you look at the basic sciences of NMDAR is that NMDA receptors are ionotropic receptors, and which play a crucial role in neuroplasticity, in memory, learning, and behavior. That's why when there's abnormality in the NMDAR antibodies, it will affect the memory and the behavior disorders in these patients. And in those patients with antibodies against the NMDAR, it usually causes cross-linking and internalization of these receptors, which disrupts the interaction between the ephrin type B receptors. And this affects the function of the NMDAR and causes neuronal injury in these patients. And some of the antagonists which have been used, which have been found, they produce the clinical syndrome which mimics autoimmune encephalitis. And these patients, they present with deficits which are clinically similar to those patients with schizophrenia. Then if you block the NMDAR receptors in the presynaptic ganglion, it affects the thalamus and the frontal cortex. And this causes dysregulation of the frontal cortex and frontal cortical functioning in these patients, and which affects the working memory in these patients, the consciousness and the emotions in these patients. And they tend to present with all the psychiatric features because of a blocking of the NMDAR receptors. And if you have excitotoxicity due to overactivity of the receptors, you can get epilepsy, dementia, and in chronic stages, you do get in Parkinson's disease movement disorders, which occur in these patients. However, in the acute presentation, these patients present with an acute psychosis. Ovarian pathologies usually has got representation of the glutamate receptors, and that's why if a patient has got an ovarian teratomas, they tend to develop a picture which is similar to that of an NMDAR autoimmune disorders. Psychiatric presentation mainly might include psychosis, and these patients will have a high titer of CSF antibodies of the IgG1 class. And most commonly, these patients have got associated ovarian teratomas. And these abnormalities, most of the time, are reversible because there's no complement activation in these patients. And neurological symptoms can range and can be variable in their presentation in these patients. They present with clinical features which can range from prodrome, whereby they present with viral-like illnesses, and usually this occurs weeks prior to the presentation. Most of these patients will have an acute viral infection before they present with the severe symptoms. And then the subsequent initial symptom which will be seen is a psychiatric symptoms. And these psychiatric symptoms occur, as I said, that they most commonly occur in the first week. Seizures are diagnostic of an autoimmune disorder, but in a patient who's presenting with a prominent acute psychiatric symptoms with a preceding flu-like or viral illness, the autoimmune disorder should be high on the list of a possible cause of the psychosis in these patients. And they tend to develop concentration abnormalities. Movement disorders, especially orificial dyskinesias, these are more likely to be suggestive in these patients. And later on, they can present with autonomic instability. In a patient who's presenting with psychotic features and autonomic instability, those are the patients you have to be suspicious of an autoimmune encephalitis in these patients. And CSF is highly suggestive in these patients. In these patients, they will have predominant pleocytosis, which is predominantly lymphocytic. And some of these patients will have high CSF protein. However, the CSF protein is not significantly elevated in these patients. And oligoclonal bands are usually positive in these patients. And the suggestion that these patients have got intrathecal synthesis of oligoclonal bands. And MRI might be normal in these patients. However, because these patients with autoimmune encephalitis might have associated autoimmune disorders, and they can have presence of aquaporin 4 and presence of MOC antibodies, that is to astrocytes as oligodendrocytes. And coming to the LGI1, most of the time, these patients are usually more than 60 years, 65 years of age, and they tend to present with progressive cognitive decline. And they have a high frequency of seizures. And a high frequency of seizures is most commonly diagnostic in these patients. In a patient who's elderly patient, middle-aged elderly patient who's coming with a new onset of psychosis with seizures, thus highly likelihood that these patients have got associated LGI1 encephalitis. And new onset seizures are mostly diagnostic in these patients. And in these patients, they can present with cognitive dysfunction, which is rapidly progressive from the initial presentation of these patients. And then they can present with focal or generalized seizure disorders in their presentation. The seizures which you usually see are the facial-brachial dystonic seizures, which are diagnostic of the LGI1 encephalitis. However, during this time, you might find that even though they have these seizures, the EEG might be normal. And these seizures, they start slowly, and you find that in some of the cases, they usually have multiple seizure episodes which occur during the day. And you might find hundreds of these because they are short-lasting. However, the awareness is preserved during this time when these patients are having seizures. And autonomic dysfunction occur commonly with these patients with LGI1 encephalitis. And some of these patients can present with a clinical presentation with the AMPA. And the AMPA-E, it has been found that these are the patients who present with confusion as the most clinical presentation, as the first presentation in these patients. And in this study, they found that when they did this, there was this study which was done in 2015. In this study, they noted that most of the patients, about 80% of patients with AMPA-E and autoimmune encephalitis, these patients, they presented more with memory deficit and confusion. The red flags, you get red flags and you get the yellow flags which have been associated with this. The red flags is a patient who's got autonomic disturbances with aphasia and patients with underlying associated seizures. And facial-brachial dystonic seizures is one of the major concern which is diagnostic in these patients. And in patients with acute psychosis, however, we've got psychomotor disorders or fluctuating features, then it's suggestive that it's autoimmune encephalitis in these patients. The diagnosis has been made by a consensus which has been made by Krauss. And this diagnosis mainly, they came up with a diagnostic criteria where they say patients must be made when 4 of the following criteria have been met, where the patient present with a subacute onset of less than 3 months. However, you do get those patients who can present, especially the LGI1 and the CASPA, who can present with a long duration of symptoms. And on an imaging, they must have a bilateral brain involvement and at least involvement of the CSF or the EEG abnormalities, and there must be exclusion of alternative cause. Imaging in these patients usually shows bilateral hyperintensities, which are noted in the medial temporal lobes, as shown in these images, these patients. And then, but in some of the patients, you might find that the initial imaging may be completely normal. And later on, you might find that some of these patients might have involvement of the meninges, might have involvement of the spinal cord. And if there's involvement of the spinal cord in these patients, you have to look for other underlying causes, especially anti-MOC and aquaporin 4 and antibodies in the patients who are presenting with these abnormalities. In a patient who's got a normal MRI, one of the other things we can look at is to do a FDG PET in these patients. And FDG PET can show features early on in the disease, and it can show bilateral temporal hypermetabolism. However, in patients with underlying seizures, remember that these patients might have associated hypermetabolism, which is noted on FDG PET. So you can get a false positive FDG changes in these patients. In a patient with NMDAR encephalitis, it's most common that you might find that there's the hyperintensity, which is noted in the inferior temporal lobe, and the insular cortex and the cingulate gyrus. So this is an image which was shown in a patient who presented with this is a patient who presented with features with headache, with vertigo and psychosis. And the imaging showed inferior temporal lobe involvement and the involvement of this insular cortex and the cingulate gyrus as pointed around. So there's involvement of the cingulate gyrus as well as the insular cortex. One of the things which we should note is that there's bilateral involvement in these patients. And even the temporal lobe, you can see that there's temporal lobe, although it's asymmetrical, however, there is hyperintensity, which is noted on the both temporal lobes in these patients. And if you've got asymmetrical involvement of the temporal lobe in these patients, you have to look for other underlying cause, which is presenting, which is a cause for the hyperintensities. With LGI1, there's mainly involvement of the temporal lobes, and it can be asymmetrical. And most of the time, because of the age and because of the presentation, then that's one of the most likely possibility you're going to think of LGI1 in these patients. And EEG is one of the most important investigations in patients who are presenting with autoimmune encephalitis. And it is one of the major cause of a new onset refractory status epilepticus, that is autoimmune encephalitis. And these patients can present with a convulsive seizures or non-convulsive seizures. And when they have non-convulsive seizures, they present initially with behavioral abnormalities with psychosis, and subsequently develop these non-convulsive seizures with altered level of consciousness. That's where the EEG is more helpful in these patients. And if the EEG just shows slow waves without any epileptiform disorders, and the slow waves are mainly involving the temporal lobes, autoimmune encephalitis should be high on the possibility of the diagnosis in these patients. However, you might find that the EEG might be completely normal, especially those patients with who are presenting with facial brachial dystonic seizures. And one of the main features which you will see in a patient with NMDA encephalitis is a so-called extreme delta brush, which is you find that the EEG there's diffuse slowing predominantly in the frontal, which is a delta slowing, and then you get a superimposed extreme fast activity on the downslope of the EEG. And these patients who've got the extreme delta brush activity, they've got poor prognosis, and these are the patients who have prolonged hospitalization and is diagnostic of autoimmune encephalitis, especially with NMDAR encephalitis in these patients. The diagnosis can be based on a tissue-based assays, which are screening methods, and then the cell-based assay, which usually detects the cell surface antibodies, and immunoblotting, which usually immunoblotting is mainly used for paraneoplastic antibodies. The antibodies, you can test them both in the serum and the CSF. However, some of the antibodies are mainly seen in the CSF, and some of the antibodies are mainly seen in the serum. Especially the LGI1 are more sensitive in the serum as compared with the NMDAR and the GABA, which are mainly seen in the CSF. So it's important when you faced with a patient with autoimmune encephalitis to do the CSF antibodies as well as the serum antibodies. A negative serum or CSF antibodies does not exclude autoimmune encephalitis. And when you have the antibodies which are positive, you have to look for the tumor association in these patients, because as we said that CASPA2 are associated with thymomas, and the NMDA are associated with ovarian teratomas. And these are the risk which the percentage which are associated in these patients. And those patients with paraneoplastic antibodies can be a high marker to be able to look for the underlying tumor. However, a positive antibody test does not always imply presence of pathogenic antibodies. If you've got some patients, you might find that some patients with underlying psychosis, especially patients with long-term schizophrenia, when you do the antibodies, you'll find that the NMDAR antibodies are positive. So you do not interpret the antibodies in isolation. It must be in the clinical setting, and the antibodies must be done in a clinical setting of a patient who's presenting with the features suggestive of an autoimmune encephalitis, especially those patients who are presenting with a subacute onset. However, you do get some of the patients who are being treated for schizophrenia, for underlying psychiatric disorders. And years later, when you do the antibodies, you find that the antibodies are positive. Most of the time, those are the patients who tend to develop deterioration. It has been found in some of the studies, these patients have deterioration and then clinical deterioration from the underlying psychiatric disorder. And then they tend to develop altered level of consciousness or new onset of seizures. These are the patients which you're going to look for underlying autoantibodies in these patients. When you do the CSF, you need to make sure that you exclude other underlying causes of abnormality on the CSF, which can mimic autoimmune encephalitis, especially HSV infection. As I said, on the CSF, you can get oligoclonal bands which are positive, which is suggestive of intrathecal secretion of the synthesis of the oligoclonal bands. However, pleocytosis and positive oligoclonal bands have got low sensitivity. However, they help in a patient who's got underlying features suggestive of autoimmune encephalitis. You do get elevated protein, and CSF autoantibodies are more sensitive, especially with NMDAR encephalitis. And you need to do bloods to exclude other causes which might be the cause for deterioration in these patients. However, one of the things on the bloods is hyponatremia, which is common, especially with the LGI1 encephalitis, which is a marker that this patient has got underlying LGI1, and you need to look for associated tumors with LGI1. There's different modes of treatment. The main thing is to try and treat the patients as early as possible to prevent irreversibility of these abnormalities. So early immune therapy, we've got first line, second line, and the third line. So the first line is aimed at reducing the antibody levels rapidly, and it can be done by using a single agent or combined therapy. And those patients who fail to respond, then you're going to go to the second line therapy. The most common first line treatment which you usually use is the methylprednisolone, which is 1 gram daily for 3 to 5 days, and subsequently you use oral taper. In those patients who present with severe illness, you might find that you need to use combination therapy, which includes intravenous IV immunoglobulin or plasma exchange. The second line therapy mainly is the rituximab. We do use cyclophosphamide because it's easier to get. And then the third line therapy, we'll go through that later on. And then the maintenance therapy is mainly the azathioprine and mycophenolate mofetil. Corticosteroids form the mainstay treatment in these patients. However, the only problem is that these are less specific in these patients. And rituximab, the major problem, the major challenge which you find is that it cannot penetrate the blood-brain barrier, and it limits the therapeutic effects. And in these patients, these are the patients who failed rituximab. You'll use in those patients who failed the first line therapy. And you find that there's a case of a patient who had antibodies and progressive symptoms for over a year, despite being on rituximab. And it was only found that he's got plasma cells, the long-lived plasma cells, which are noted on the lymph node, and which results in the multiple relapses and refractoriness to the treatment in these patients. Plasma exchange is found to be much more beneficial in this patient, or that is plasma exchange or immunoadsorption, and it removes the antibodies rapidly and causes rapid improvement in these patients. And it has been found that after treatment with plasma exchange, about 97% there's a decrease of about 97% in the serum and a decrease of about 64% in the CSF of the autoantibodies. Combined therapy with corticosteroids, commonly corticosteroids with a plasma exchange or IVIG, is mainly in those patients who are presenting with, especially the new onset refractory status epilepticus, or with severe disorders or severe dysautonomia. And the second line agents commonly which we use is a cyclophosphamide. However, rituximab is one of the drugs which shows better efficacy as compared with the other drugs. And then the third line treatment. The third line treatment is mainly for those patients who fail on the first line and the second line treatment. And the third line therapy is mainly treatment which is targeted at the long-lived plasma cells. And these drugs which are used for long-lived plasma cells are the daratumumab and the bortezomib. These are the drugs which are ideally attacking those long-lived plasma cells, especially which result in a patient with refractory to treatment. And then you use the other immunotherapy drugs which are able to pass through. This drug is able to pass through the blood-brain barrier. Remember that rituximab has got difficulty passing through the blood-brain barrier and also has got difficulty penetrating into the lymph nodes, into the long-lived plasma cells. So that's why you're going to use the third line agents. And then these other are just mainly to alleviate the clinical symptoms of these patients, especially the low dose interleukin-2 and the rapamycin. So there's always the challenge of that patients with underlying psychiatric disorder might worsen when you use steroids because of the steroid-induced psychosis. However, the risk of psychosis is low in these patients And remember that you're using the steroids for a short period of time, and then subsequently you're going to use the steroid sparing agents. And you can use the antipsychotic medication. However, you need to look for extrapyramidal side effects as well as the NMS as a side effects in these patients. And those patients who present with catatonia, high doses of lorazepam has been used with good effect. ECT has been used, especially those patients who presenting with autoimmune antibodies against GABA and who presenting with catatonia. However, it has been found that in some of the cases, especially those patients with NMDA encephalitis, they do respond with ECT, although it's only a few studies which have been seen in these patients. And lithium and valproic acid has been used to control the manic episodes in these patients. And you find that those patients with presenting, especially the facial dystonic seizures, these are the patients who respond quite well to the immunotherapy, especially to the corticosteroids. And then you can use the central anticholinergics for the movement disorders, and baclofen can be used in these patients. And in those patients with paraneoplastic autoimmune encephalitis, immunotherapy does not have significant effect. It has got little effect unless you remove the underlying, you treat the underlying malignancy. And in those patients with NMDAR encephalitis, it's important to look for underlying ovarian malignancy. And if you remove the ovarian malignancies, these patients are the ones who will present, will have a faster recovery in these patients. There's quite a few complications which are mainly related to the treatment of these patients rather than related to the underlying autoimmune encephalitis. And approximately 75% of patients with NMDA will recover with mild sequelae. However, they get about 6% mortality in these patients. The mortality is most commonly related to delay in treatment in these patients. And about 25% of these patients might have severe deficits which are present. And anti-NMDAR antibodies which are present in the CSF and the serum, you might find that these patients, when you check them months or years later, even despite being on treatment, they will persist. So persistence of these antibodies, of these autoantibodies, does not mean that the patient has got underlying autoimmune which is active, unless the titers are increasing or the patient is showing progression of the disease. There have been some potential biomarkers. These biomarkers, if you pick up these biomarkers on the serum, then it's suggestive that these patients are most likely going to have poor response, especially if the biomarkers are picked up on the CSF. If they have these biomarkers on the CSF, you need to go to the second-line therapy and most likely motivate for the third-line therapy because of the poor penetration of rituximab onto the CSF. And some of the patients with LGI1 and autoimmune encephalitis, they've been found to have good response with steroids and usually with good outcome. However, because of the complement activation with the LGI1, they tend to have long-term cognitive problems and atrophy of the limbic system in these patients. So despite the treatment and despite the clinical improvement, they will have long-term cognitive impairment. So if you start the treatment early and aggressive treatment, then these patients have got good prognosis. However, those patients who fail the first line and require second line, it needs to be started early. If it's started early, then they've got good outcome in these patients. So when you have a patient which you suspect that the patient has got autoimmune encephalitis, what you're going to do is to do an EEG and an MRI, and you do a lumbar puncture and do a blood, look for the neuronal antibodies. In a patient who's got a negative, a normal MRI, a normal EEG, however, in the lumbar puncture and the serum shows positive autoantibodies, those are the patients which you're going to order an FDG PET in these patients. And if on the whole body FDG PET, you will be able to pick up even the small malignancies, especially testicular tumors, are most commonly missed by ultrasound or by CT scan. That's why FDG PET is important in these patients. And once you identify autoantibodies in these patients, or we've got high suspicion that this patient most likely has got autoimmune encephalitis, acute immunotherapy with IVIG or plasma exchange. Plasma exchange, especially in those patients who've got a thromboembolic risk, because IVIG increases the risk of thrombosis in these patients, then you need to use plasma exchange. And in a patient who's presenting with severe illness, that's when you're going to consider combination therapy. If a patient is not improving 2 to 4 weeks after the combination therapy, you need to go to second-line therapy. And if a patient fails to respond, then you're going to use the third-line therapy in these patients. So autoimmune encephalitis, you must have a high index of suspicion, and remember that some of these patients will have the autoantibodies which are present despite not having underlying autoimmune encephalitis. However, in the clinical setting, you have to think, does this patient have autoimmune encephalitis based on the clinical presentation, acute or subacute presentation of psychotic disorders, presence of seizures is suggestive that this patient has got an autoimmune encephalitis. And one of the things with those patients with autoimmune encephalitis, they respond so well to immunotherapy. So if they are treated early, you might find that you get reversibility in these patients, except for those patients who are elderly with LGI1 and autoimmune encephalitis, which will, although they will respond, but the main thing, they will have long-term cognitive sequelae in these patients. And combination therapy should be started as early as possible. And maintenance therapy, there are some of the questions which are unanswered, is that how long do you maintain them on maintenance, on long-term maintenance therapy? Because these patients, you might find that they need to be on treatment even for years because of the relapse. Sometimes you might find that some of the patients relapse even 2 years after you stopping the treatment. So those are unanswered questions around how long do you continue with the maintenance therapy. Thank you so much. I'm sorry about all this problem with the network initially. Thank you.
Thank you. Thank you, Dr. Dlwati. Wow, that was an excellent, superb presentation, very informative. So thank you for all the efforts that you've put into this presentation. And yeah, and thank you as well for making up for lost time, because I know we started late, but this was an excellent presentation. And I know there's going to be a lot of questions that are going to be directed to you by the audience. Before I hand over as well to Professor Tiliza for his comments, I just wanted to ask you, while everybody else is as well is thinking about their questions that they're going to ask you, at Albert Luthuli, I mean, is this condition common? How many patients do you see average per year, and what is the source of your referral? Are they coming directly? Do some of them come from psychiatric units after being worked up there? So who's your main referral pipeline for these cases? Thank you.
Thank you, Dr. Enika. We see quite a number of patients with autoimmune encephalitis. However, most of these patients are coming from the base hospital because most of these patients, they tend to present with altered level of consciousness. Although they present with new onset of psychotic disorders, and because these patients, they get admitted to the base hospital with a new onset of psychotic disorders, and then subsequently they develop altered level of consciousness. And most of the patients which we have seen in our department are those patients who have altered level of consciousness. Because of altered level of consciousness, these patients, they end up with our neurology department. And most of the patients, we've worked up some of these patients with to find ovarian malignancy, ovarian teratomas. Actually, we haven't found any ovarian teratomas. We've done a full body FDG PET in these patients. However, we haven't found any ovarian teratomas, even though we find that there's a high risk of ovarian teratomas. We've usually, in most of the time, we see these patients during the winter season because of the preceding flu-like illness. They tend to have preceding flu-like illness, and then subsequently, these patients develop acute psychosis and then behavioral abnormalities. We've had a patient who was a 24-year-old. This patient stayed in ICU for about 2 months, and this patient required 3 cycles of plasma exchange, despite the immunosuppression. And this patient had refractory seizures. The problem we have is that getting rituximab is a major problem in our setting, in the neurology department. So you find that we have a problem accessing rituximab. So what we're able to get is a plasma exchange, and then these patients will be able to respond. And subsequently, she's got minor cognitive impairment post-discharge. We're still following her up, but she's on long-term immunosuppression in these patients. On average, we see about 6 to 8 patients per year with autoimmune encephalitis, and most of the time it's an acute presentation. Thank you.
Okay, thank you, Dr. Dlwati. I see Dr. Nene Kangisile has a question. Would psychotherapy be useful in managing such patients?
Psychotherapy would be useful mainly to treat the underlying psychiatric abnormalities. However, the mainstay treatment in these patients is immunotherapy. They need to be on immunotherapy. Immunotherapy will reverse most of the presentation in these patients.
Okay, thank you. Professor Celiza, any comments?
Sure, thanks Basil. Thank you so much, Luthuli. That was fantastic, very nice presentation. I think what I wanted to ask you from a psychiatrist's point of view is that we often wonder if we are not perhaps unwittingly sitting with some of these patients in our wards and treating them as what we might call treatment-resistant schizophrenia. We keep trying different antipsychotics and they're not working. Particularly, I guess, in this era of HIV, because I think a lot of our patients have HIV, and as you know, the HIV also influences the presentation and makes them look a little bit delirious at times if they're HIV psychotic. So I'm just wondering about, what do you think? Do you think we are missing them, or is that really is the clinical presentation so classic that we should be able to pick these up and send them to you quite swiftly?
Okay, thank you, Prof. Celiza. One of the things is that these patients, most of the time, you do get those patients who present with a subacute chronic presentation, especially with the LGI1. And these patients will present with a progressive cognitive dysfunction. However, those patients with an acute or subacute presentation, it's easier to identify them. There have been some papers where they found that there's a patient who was treated for schizophrenia for 2 years. And subsequently, this patient, but the main thing which was noted on this patient is that this patient developed an dysautonomia. When the patient developed dysautonomia, that's one of the features which was pointing towards, could this patient be having an autoimmune encephalitis? As I said, that you'll find that if you treat this, if you screen these patients for autoimmune encephalitis with the neuronal surface antibodies, autoantibodies, you'll find that some of these patients have got an autoantibodies which are positive. However, in the clinical setting, because there's a criteria which has been provided by Cross, and it's not include, you must not just look at the autoantibodies alone. You need to look at the neuroimaging and the EEG or CSF findings in these patients and look at the clinical features in these patients. However, the HIV can cause all these abnormalities. So in a patient who's got underlying HIV, was presenting with an acute or progressive psychosis, ideally it's better to screen those patients for an autoimmune encephalitis. And because if you screen for autoimmune encephalitis and you find that the antibodies are positive, then those are the patients which you're going to progress to look at imaging. And in the setting where you think this is an autoimmune encephalitis, those are the patients which you're going to consider doing FDG PET in those patients. And there was another question on COVID. We haven't found any cases, there hasn't been any significant papers which say that with the COVID infection, the number of autoimmune encephalitis has increased. We're seeing some cognitive dysfunction which has been noted with COVID, but I think probably because patients who've got COVID who are positive with who are COVID positive with psychiatric disorders or with cognitive impairment, these patients, they tend to be put on steroids early on. Probably we're not seeing these patients presenting with features suggestive of autoimmune encephalitis. So COVID, we haven't found any patients or any increase in autoimmune encephalitis related to COVID.
Thank you, Dr. Dlwati. There's a comment as well. Great presentation. Thank you. Is it possible for us to please get a copy? I think a copy will be made available to everybody. I think it will also be posted on the Department of Psychiatry website. Yes. Any questions from the audience? You can just unmute yourself and pose a question or raise your hand. While people are thinking about the questions, I mean, it's quite interesting that, and I will direct this question as well to Prof. That you made mentions as well of biomarkers such as the NSE and the S100B. I mean, this in neurosurgery, these biomarkers as well, because biomarkers are they show you the level of injury to the neuronal tissue, and they can be used as prognostic markers. From a psychiatric review, is there a role, Professor Trilisa, of biomarkers in psychiatry? If you can comment about that, just an interesting question that I was thinking of.
Yeah, thanks, Basil. Yeah, no, there is definitely a huge role for biomarkers in psychiatry. A lot of the work at the moment has been on trying to find the correct and easiest biomarker to use for some of the psychiatric disorders. And I think we are some way away in trying to work out what those are. At the moment, there's a few sort of tentative ones that have been I've spoken about, which range from some of the cognitive assessments that we do to some of the blood tests and CSF markers. But it's not yet routinely, it's not yet at the level where it can be clinically sort of applied, such that we use it sort of routinely at the moment, unfortunately. But the other thing I just want to say is that Dr. Taylor, Lindo Taylor, is also very interested in biomarkers, and I think that's his area of interest for hopefully for his PhD and going forward. And he'll be maybe in a year or so be talking to us about some early results of his PhD about looking at biomarkers, and he's interested in sort of CSF and HIV-induced psychosis.
Thank you, Prof. Trilisa. Dr. Dlwati, just to come back to you, I mean, with these patients have refractory seizures, how do we manage them? Because looking at those MRIs that you've seen as well, you can see there's always hypothesis hyperintensities are in the temporal lobes, and we know, the temporal lobe can be is one of the most epileptogenic areas in the brain. So what approach to these cases when they present with refractory seizures?
So basically, those patients who present with an new onset seizures, refractory seizures, one of the ways which you usually treat them, we treat them as a autoimmune cause of the seizures, autoimmune seizures. So the main thing which we usually do is to put them on high dose of steroids. So these patients have to be put on IV methylprednisone. And if these patients do not respond, despite inadequate anti-epileptic treatment, patient must be on adequate anti-epileptic treatment. However, one of the things we need to look at is that if the patient is having seizures, is it autoimmune encephalitis or is it related to another pathology? Those patients who've got autoimmune encephalitis tend to not respond to the anti-epileptic treatment. However, if it's due to another pathology which is causing the seizures, these patients, they will respond to the anti-epileptic drugs. However, we'll have to use IV methylprednisolone. And if the patient still does not respond to this, to the anti-epileptic, to the methylprednisolone with anti-epileptic treatment, those are the patients which we try them on IVIG or plasma exchange, depending on the availability, which one is available. However, plasma exchange, it will remove the autoantibodies rapidly. So the plasma exchange is a better one. It's a better option than as compared with IVIG in these patients. So the treatment option includes IVIG, plasma exchange. Failure to treatment, if they fail those patients, those are the patients which you're going to use combination therapy, where you're going to look at using cyclophosphamide, which is easily available. Rituximab, we do get it after, but you have to demonstrate that there's failure with cyclophosphamide, there's failure, or the patient requires multiple doses of plasma exchange, and then that's when you'll be able to get rituximab before you go to the third-line therapy. We haven't had any patients who require to go into the third line of treatment.
Thank you, Dr. Dlwati. Prof. Trilisa has a question. Any role of pulsing the people with high dose steroids while waiting for results, perhaps in the rural setting?
Yes, definitely. That's one of the things, is that if you've excluded infection, you need to make sure that you exclude infection. If you do a CSF and CSF shows predominant lymphocytosis or high CSF protein, however, you're not finding any cause of infection, there's nothing to suggest that this is a TB meningitis or anything, pulse these patients with methylpred, especially if the patient is presenting with the clinical features, because remember that the autoantibodies, they take time, because sometimes the autoantibodies take about 4 weeks to come back. So in the meantime, while we're waiting for the autoantibodies, pulse these patients with IV methylprednisone and then see the clinical response, and just make sure that there's no infection in those patients. And then in the rural setting, pulse with methylpred and try and see if you can get a form of imaging. CT scan does not usually show the features of autoimmune encephalitis. So ideally, these patients require MRI imaging, and in some of the patients, FDG PET scan.
Okay. Thank you, Dr. Dlwati, and thank you again for such an excellent, world-class presentation. I'd like to thank everybody who made themselves available as well for this great lecture. And I'd like to close the session now and wish everybody a wonderful weekend. We're going to meet again next month, the first Friday of June, and hopefully we'll have an interesting and wonderful lecture for everyone. Thank you again, Dr. Dlwati, and thank you so much.
Thank you so much, Paisan. I'm sorry about all that. Thank you to all the participants.
No, that was beyond everybody's control. Thank you, Dan.
Thank you.
Bye.
Have a good afternoon and a good week.
Okay. Bye. Thanks.